Hello, everyone. Welcome back to another Journeys in PPI webinar with the Mum Predict Research Project. I'm very pleased to welcome Miranda Scanlon along with us this evening. So Miranda was one of my mentors when I first got involved in research through the National Childbirth Trust. And I only later on found out that Miranda had not only got whole on maternity experience, but she'd also been a kidney patient for most of her adult life. And so she, after all her maternity experience, she's now working mainly in PPI with kidney patients and so on. So it's going to be, we always have some really interesting conversations, Miranda and I, about different areas of health and how PPI is the same and different in those. So over to you, Miranda. It'd be lovely to hear more about your journey to get to where you are today.
Thanks so much, Rachel. I'm just going to share my screen and hope that that all works as it should. And just going to arrange a few notes I've got. I'm afraid that it's a little bit longer than it should be probably, but I'm afraid I didn't really have time to edit it. But thank you ever so much for the invite. And I'm sorry for postponing it due to my flu. My flu is just about better, but I'm still a little croaky, so I hope you'll forgive me for that. It's been really interesting to look back on and see my journey in public and patient involvement and engagement. I've been doing it for so long that it wasn't even called that when I started it. This presentation does seem a little bit sort of self-indulgent, but I suppose it is my journey, so it is a bit sort of me. But as I've been doing it, it's really brought up a lot about how it's changed, how particularly access to information and data has changed since I started out, and the ways that we get information. So I'll kick off and hopefully everything will work. So there have been two main strands in my life which have led me to being an active user of healthcare services and wanting other people to have that opportunity. So the first thing is that I was diagnosed, as Rachel said, with a progressive kidney disease at the age of 18, which led to kidney failure and me having a kidney transplant. And the other thing was me having my two children and experiencing maternity services as they were in the mid-1990s. And I'm going to start with my maternity journey because I guess that's what everybody's a bit more familiar with. So the background is that my mum was a doctor and she had 5 children. There's just 4 of us here, one in a pram. She had us all naturally, and one was a home birth. And she regarded giving birth as easy as shelling peas, and she breastfed all of us. And she disregarded the instructions of the district nurses at the time, who told her she had to do strict 4-hourly feeds for the babies. And instead, she kind of followed all the controversial Spock method of demand feeding. They were all horrified, but they couldn't say anything because she was a doctor. And then when I was 14, one of my older sisters had a baby, and she was also really keen for this birth to be as natural as possible. But that really wasn't very easy in the 1970s. But she was reading books like Birth Without Violence by Frederick Leboyer and Spiritual Midwifery by Ina May Gaskin. And I read those books at the same time as she was pregnant. And those books really formed the basis of how I felt about childbirth. And that stayed with me for the next 15 years until it was my turn to have children. So my mother-in-law had also had home births and breastfed her children, and so had my sister-in-law. So I was pregnant in an environment and a family culture that really supported a belief in the body's ability to give birth and to nourish children. So off I went to the GP when I was pregnant, and he told me where I was going to have my baby, which was in a local hospital. But I'd already done my research, and I knew that I didn't want to go there, and I wanted to have a different model of care. So I wanted a domino delivery. Now, if you say domino delivery to anybody these days, they think you're ordering pizza. But that's not what it was in those days. A domino delivery was domiciliary in and out. And this was a team midwifery model where you had a named midwife who you got to know and a backup midwife. Your antenatal care was all done at home or at a local clinic with that midwife. When you were in labour, your midwife visited you at home and either went away and came back, or she stayed with you, depending on the stage. and you only went to hospital at the later first stage, and the midwife went with you. You gave birth in a home from home room with lovely flowery curtains, and then you're on a 6-hour discharge after the birth. So it wasn't easy to arrange. It meant going to a different hospital and a different system of care. And the GP wasn't really very happy about that. So essentially for me, it meant getting off the conveyor belt. And I found that they were very keen to pop you back on that conveyor belt whenever they could and back to consultant care. And I had to work really hard to keep on that domino track. I also attended NCT antenatal classes. This is their old logo when they were still the National Childbirth Trust. And I read so many books. I just wanted to gather as much knowledge as I could to do those births right for me. My mother-in-law gave me her original 1955 copy of Grantley Dick Reed's book, Childbirth Without Fear. Fascinating book. And I read all the other books of the time, Janet Velasquez and Her Active Birth, the NCT book, Sheila Kitzinger. This was a very medical book by an obstetrician, but it was full of information. And then this last one, Miriam Stoppard, this is the one that my husband rushed out and bought when I went into labour. He'd obviously suddenly clocked that we were actually having a baby and he'd have to look after it. So he rushed out and bought that. So I got my 2 domino births. The first baby I had preeclampsia and I ended up having a hospital stay. So you can see me in the ward there. But the second one was a classic domino. I went in about 1 o'clock in the morning, had the baby at 8, and I was 8 in the morning, and then I was home in time for lunch. You can see the lovely flowery curtains there in the home from home room. And you have to excuse my bad hair day. So before long, I realised that whilst I wasn't going to have any more babies, all of the knowledge that I gathered might be helpful for other couples having babies. So I went back to the NCT and trained as an NCT teacher, NCT antenatal teacher. So again, lots of books, and it just reminded me that, you know, this was how we learned. We didn't have the internet, and so all of our learning came from all of these books. This led to a diploma in antenatal in higher education for me, and this is how I met Rachel, through being an NCT teacher. But what being an NCT teacher also gave me was a huge amount of knowledge about how women and their partners experience maternity care and what was important to them. And also importantly, it gave me training in group facilitation, listening skills, how to draw out people's concerns and expectations, discuss sensitive topics, and also how to empower people to be active in their own healthcare and negotiate their care with their care providers. And it was during this time that I thought a lot about the conveyor belt of maternity care and how women were giving birth in places that didn't really result in the birth that they wanted. So, for example, you know, a woman might say to me, I really wanted a water birth, but the hospital I'm going to doesn't have a pool. Or I'm hoping to have a cesarean, but the hospital I'm going to, a third of women have a cesarean. So there seemed to be no real support for women to choose to have their babies where they would get the experience they wanted. And as a result of that, with a friend, I set up the Birth Choice UK website, and this was helping women choose where to have their baby. Now, this was back in 2001, and websites were new in those days. You accessed the internet through a dial-up modem. There was no broadband, so everything had to be very simple. There were no pre-made websites like WordPress. So we wrote everything from scratch in code in HTML. So this is one of our original flyers from the 2001 launch. And the back of this shows how the website guided women through making decisions about helping them think about the sort of birth they wanted, what were their local options. There were some maternity statistics on the website and sort of questions that they could ask care providers, and shown how to book. And really the philosophy of the website was in the final bullet point. It says, this website does not tell women where to give birth. Instead, it encourages women to ask questions of themselves and their healthcare providers to help them make choices which will result in the birth experience that they wish for. So I haven't got the original website was in colour, but I've only got some black and white screenshots of it. So this was a checklist that you went through. that it was the kind of the backbone of the website. So women on the website went through the list of went through all this list through and clicked onto the list of questions, finding out all about the different options for birth, looking at the maternity statistics, and the website ticked off everything. Once they'd visited a link, it ticked it off, so they knew what they'd done. We also had questions that they would ask themselves about, companions or their environment. And those little buttons that say research, they linked through to pages of referenced research so that women could find out, what the research was about, one-to-one care in labour or pain relief or birth environment. And then this was in colour and it looked a little bit brighter than this, but this is how we set out the maternity statistics. So a unit would have sort of induction rate, caesarean rates, and it would be compared with a few local units and with the national average. Now, we managed to source maternity statistics for individual maternity units. We got these from the Department of Health, and this was the first time that maternity statistics had appeared on a website. At the time, the Department of Health was only publishing them in paper form. They just had a big cupboard of paper bulletins. And so this was really innovative. For the first time, women could access maternity data via a website that they'd never seen before. They were like gold dust before that. So these statistics were updated annually with new statistics, and we added any sort of new research to the website. And over time, my colleague Rod Gibson and I were given direct access to the hospital episode statistics maternity data. And we could develop our own new indicators, and some of those were adopted by the Department of Health and NHS Digital, as it later became. Things like normal birth rates and birth without intervention. So this might look just incredibly old-fashioned, but it was actually really innovative. And when it was launched, we had this fantastic reception from birth professionals. Sheila Kitzinger said, "It's a remarkable new website which will be of help to women making choices about birth." Mary Newburn said she was very impressed and she thought it was all excellent. Caroline Flint said it was totally brilliant. Jane Sandel said it was a wonderful resource. And women really liked it as well. So they said it was easy to navigate, simple to understand, brilliant, concise but straightforward. They were really impressed. It was the best site that they'd visited. It was sensible. And this was wonderful news for us because, we put a lot of work into it, and it was just brilliant that, it was valued by women and it was going to be of help. And in fact, the Birth Choice UK website ran for 15 years on an entirely voluntary basis. And, we really do think that it was very pioneering at the time. For me, it opened a lot of doors for me to be on committees, deciding policies and determining the direction of maternity services. So I was able to get really involved as a maternity service user and freelance researcher on lots of projects and worked with many wonderful people. So I worked a lot with the NCT on many of their publications and reports, and worked a lot with Rachel at the time. I worked with the Royal College of Midwives on various projects, including the Midwifery 2020 programme, which actually happened in 2010. I was an advisor to the Care Quality Commission on their surveys on experience of maternity care. Birth Choice UK was a stakeholder for NICE maternity guidelines. I wrote some of the informed choice leaflets for MIDAs. I was on the Maternity Care Working Party and the RCOG Women's Network. And I was also on the development group for the new maternity services dataset, which is what's used at the moment. So it was a real privilege for me to be able to represent the needs of maternity service users in so many different ways. And I also worked with some really inspiring campaigners. So Mary Newburn and Elizabeth Duff of NCT, Beverly Beach of AIMS, who we miss greatly, Sue Down and Sheena Byram, who midwives who worked. All of these people really committed to improving care for women. So the next major event for me was being approached in 2013 by Which, the consumer organisation, and they wanted our help to build a website helping women choose where to give birth. So for us, the timing was perfect. It was really hard keeping the Birth Choice UK website going on an entirely voluntary basis. It was really out of date. It was still sort of designed for that dial-up modem and written in HTML. So it needed revamping, but we just didn't have the time or the resource. But which had money, and it had a web design company. And as a result of that, the Which Birth Choice website was born. It was a rather fancier website than Birth Choice UK, I have to say. But fundamentally, it had very similar things, a lot in common. Information about choices for childbirth, different places you could give birth, articles about maternity care, and help with decision making. So a key feature of this website was a decision making tool. And this used an algorithm to help women find the best place to give birth. So it's, the beginning of it's not shown here, where women would put in some information about their age and their location, whether they were having a first baby, whether they had any significant risk factors, like having had a previous cesarean. And then they answered some of the questions about what they thought about birth. So did they want to use a birthing pool? Did they want an epidural? How did they view birth? You know, was it a natural event that should be in a relaxed private setting, or a clinical event that needed medical equipment and staff on hand? And the women could move these sliders across to you know, fully engage with one side or the other. I don't want a birth pool, I do want one. Or they could leave their options open, or they could move the slider partway across to have a sort of more nuanced response. And the algorithm was designed to take all of this into account, and it used evidence-based information such as the NICE guidelines on where women should give birth. And it came up in sort of typical Which fashion, with your sort of best buy. So in this case, it came up with a best fit of the best place for you to give birth, to get what you want to match to your preferences and your circumstances, and also gave sort of a good fit as well. And it also showed on the side how it matched to your preferences. So this must have been somebody who was in sort of South London, who didn't want an epidural, who wanted a pool, who wanted to be on a hospital site and wanted a more sort of relaxed and less clinical setting. So we basically left Which, you know, once the website was up and running, we left them to it. And Rod and I became rather more involved in academic research. And we were particularly working with projects that used the Haresley hospital episode statistics data. So one of the projects was, they were both NIHR projects we were involved with. One was at King's College, working with Jane Sandel, and that was on the efficient use of maternity workforce and safety and quality in maternity care. And then the other project was at City University of London with Alison McFarlane. And this is what was called the birth timing project for short, the birth and their outcomes by time, day and year. So Rachel's probably told you quite a bit about the birth timing project. I was involved in phase 1 of the project, looking at how the time babies were born affected outcomes. And as you probably know, I'm going to just talk a little bit about this. As you probably know, it was a data linkage project. And we started off so we had 3 data sets. We started off in the centre with the birth registration data set. So this is the information that's collected when a baby's birth is registered. And that's a very complete data set because virtually everybody registers their baby to get the birth certificate. And this was linked, first of all, with the one that's shown in green, the birth notification data set. And this is the one that issued NHS numbers for babies. And very importantly, this data set had the time of birth, which is the only data set which had time of birth. So it's important to link to that. And we linked the birth registration, birth notification, linked with sort of the items they had in common, fields they had in common. So baby's NHS number, date of birth, the home postcode, and the mother's date of birth. The birth registration data had a lot of demographic data, but it was missing clinical data. And so that was linked from the hospital episode statistics data, using, again, some linked items: baby's sex, home postcode, mother's date of birth, mother's NHS number. And we did this for 10 years of maternity data for England, and that ended up being 7 million birth records. And these are all processed and stored in the secure data lab at the ONS. And this gave us a really kind of rich data set that we could work with. And as you probably gathered, I had a particular interest in place of birth, and so we got some data out of the project about that. This is the 7 million births condensed down into one 24-hour clock. So this sort of amalgamated all of the years and all of the seasons and came out with an overall pattern. Probably the most interesting place to start is with the home births, which are the ones in green. And these are the births that took place at home, so are likely to be sort of more natural births, no interventions, and when mothers would go into labour naturally and give birth naturally. And you can see this sort of this wave, this circadian rhythm of most of the births, the highest number of births being at 4 o'clock in the morning and the lowest number of births at 4 o'clock in the afternoon, which is just interesting in itself, I think. Then looking at the red numbers, that's the freestanding midwife-led units. Again, much less intervention happening. And so still this pattern. These are women who are not generally having interventions, just being looked after by midwives. But still some patterns, not quite the same as giving birth at home. And then the other lines, the dark blue and the light blue, are babies that are born in obstetric units, including ones with alongside midwifery units. We couldn't separate those out because they're all on the same site. And you can see this huge number of babies being born between sort of 9 and 12 in the morning. And other analyses showed that these were babies who were being born by elective cesarean section. But you can also see that, you know, there are far fewer babies being born between sort of 6 and 8 in the morning. So a real difference to the natural pattern of birth from the home births. But one of the really interesting things about this project was the way the PPIE was structured with our three-tiered approach. So we had 2 service user project co-investigators on the project. That was Mary Newburn and me. We were paid for our time. We went to all of the project meetings and helped develop the project as it went along. And we co-authored the publications. And then we had 2 other tiers. We had the maternity service users who were members of the project steering group. And we also had a much wider engagement with the larger numbers of maternity service users in the public. And this was done largely through workshops and a focus group. And Rachel helped us a lot. She was working at the NCT at the time. She helped us a lot with organising those. And as I'm sure you know, we wrote that up in the International Journal of Population Data Science. So that's a publication by Mary, me, Rachel and Alison McFarlane. And you might also know that we won an award for this. We won an ONS Excellence Award for the work we did on the birth timing study on PPIE, which was very pleasing for us all. So that was my timeline: babies, NCT teacher, Birth Choice UK, and all the things that went around it, and which birth choice, and then the NIHR projects. But alongside all of this, I had another story going on, which was my kidney health. And so, as I said earlier, when I was 18, I was diagnosed with a kidney disease, a condition called polycystic kidney disease, or PKD as we call it. And this is a condition which causes cysts to grow in the kidneys over time, and it gradually reduces the effectiveness of the kidneys. And in some people, it ultimately causes kidney failure later on in adulthood. PKD affects 1 to 2 in 1,000 people, and it's caused by a genetic mutation. And it's one of very many kidney diseases, which overall actually affect about 10% of the population. And when I was diagnosed with PKD, there was literally no information about it. I wasn't given a leaflet. I think maybe the people who diagnosed it maybe told me a little bit about it. There is a really great PKD charity, but that wasn't established until 20 years after I was diagnosed with PKD. So I just basically knew nothing about it, and there was nowhere to find out anything. So kidney function is measured by something called eGFR. That's estimated glomerular filtration rate. And it can kind of be roughly converted into a sort of percentage of kidney function. So that if your eGFR is 90 or higher, then your kidneys are working pretty well, 90 to 100% working really well. as kidney function deteriorates, it usually happens over time, but the time varies. And so there are stages, and they're marked by different sets of EGFR. So by the time your EGFR is at stage 4, it's under 30, then you've got severe kidney damage and your kidneys aren't working very well at all. And by the time it's less than 15, you're just pretty well, your kidneys just aren't working, and you're not in a good way, I have to say. So for EGFR, it's actually an equation, and it's calculated on a couple of things, sort of age, but one of those things is something you need a blood test for, and that is your creatinine blood levels. And creatinine works in the opposite way to EGFR. So as your EGFR gets lower, your creatinine rises. So a rise in creatinine shows that your kidneys are working less and less well. And this is a graph of my kidney function over the years. And you can see it starts sort of in 1997. And you can see that my creatinine was sort of gradually rising. But there's an exponential curve. And you can see when I really began to suffer from kidney failure, reduced kidney function, moving on to kidney failure. And this was sort of in the years really sort of 2004 to 2006. My kids were primary school age, and I really wasn't at all well. I had anemia, I had fatigue, I had nausea, brain fog, and I really couldn't function at a great level, and I had to sort of step my life down and do as little as I possibly could. At this point, when my kidney function was at its worst, my EGFR was 8. And then you can see that something really quite dramatic happened to my EGFR and my creatinine, and my creatinine levels just dropped, and they've been pretty much stable ever since. And what happened in 2006 was I was really lucky to have a living donor kidney transplant from my sister. And you can see, I mean, the kidney just started working immediately and hasn't stopped. And in fact, I had my creatinine measured yesterday, and it's 82, which is an EGFR of 67. And the effect of that on my life, it was like a miracle. I mean, it's such a transformation. And suddenly I was able to lead pretty much a normal life, albeit immunosuppressed. I had to take care with a few things, and there were sort of a few, health issues. I get monitored every 3 months. Still, this is nearly 19 years later. But the difference that transplant made to me has been absolutely incredible. But as you can imagine, around this time, I was having a lot of kidney care. I was in hospital a lot, dealing with all sorts of things. And so my mind was very much on, after my kidney transplant, thinking about the experience of kidney care. And so I then got involved a little bit in some patient representative work in kidney health. And I was on some guideline development groups. I was on the chronic kidney disease guideline that published in 2008, on the anemia management in people with chronic kidney disease published in 2011. And then this really great guideline, it's a generic patient experience in adult NHS services. I was on the version that was published in 2012, but it's been updated more recently. And it's such a fantastic guideline. So full of ways that patient experience can be enhanced using NHS services. I also got a bit involved in shared decision making in kidney care. I wrote this article for the British Journal of Renal Medicine, and I did some work on renal disease in pregnancy. But really, eventually, I had to make a choice. I was doing so much work in kidney, and there was so much to do in maternity, and I couldn't do both. And so I made a choice, and it was around the time that Which Birth Choice was kicking off. And so I stopped doing the kidney work, and I just focused on maternity. But then COVID-19 came along, and at the time of the pandemic, I really began thinking a lot about kidney care again and getting involved. As an immunosuppressed kidney patient, I was profoundly affected by the pandemic, along with, 500,000 to 1 million other immunosuppressed patients. I had to shield for a couple of years. Before the vaccinations arrived, 1 in 4 people with a kidney transplant who caught COVID died. So for me, it was kind of worse odds than Russian roulette. And my whole life became about avoiding contact with COVID. And this is an article I wrote about being a kidney patient during the COVID-19 pandemic. But you can see this was written just before Christmas 2021. So this is nearly 2 years into the pandemic. And this article is actually on the Kidney Research UK website. It's really saying that, you know, it's not quite the same as early on in the pandemic when it could literally be a death sentence. But just trying to avoid, you know, getting ill, avoiding COVID really meant leading a very, very isolated life indeed. So after about a year of lockdown and shielding, I saw an advert, a recruitment ad for the lay advisory group lead for Kidney Research UK, and I decided to apply for that. And I got that role. And so that is what I've been doing for the past 4 years. And I really thought that all of my years of work in maternity on women's experience in maternity care and being involved with research would have fully prepared me for a role in public and patient involvement in kidney research. But it has really been quite surprising. Of course, there are similarities, but there's been some real differences to get my head around. So first of all, kidney disease tends to be a long-term condition. Once you've got it, you've got it. And we're often patients for a very long time. So I've been a kidney patient, as I said, all of my adult life, over 40 years, whereas I was pregnant for just 9 months twice. But what this means is that we quite often become experts in lived experience. You know, we are very familiar with our condition, with our treatments. We know what makes us worse. We know what makes us better. And this can give us some real insights and very valuable insights that we can contribute to research. We also have very specialized treatments. Dialysis is quite an unusual thing that no other condition has. You know, it's just for kidney patients. And transplants, whilst there are other transplants, lung transplants and heart transplants, the majority of transplants are kidney transplants, and you know they're quite a different treatment to other things. We also have a big reliance on pharma because you know I mean I'm on immunosuppressants. I'm completely reliant on those, and so we have much closer ties with industry than we ever had in for maternity care. We have quite a lot of sort of complex decision making around, particularly around these sort of specialist treatments we have, and whilst you know maternity care involves sort of life and death decisions, I think the ones for kidney patients can be really quite difficult around you know choosing what kind of replacement therapy you might have or not, and the burdens they have. There are some real inherent inequalities in kidney disease. It affects some communities, particularly Black and South Asian communities, more than others, and that's exacerbated by inequities in treatment. And we also have a lot of comorbidities. Quite a lot of kidney patients are kidney patients because they've got diabetes, or also we have a lot of cardiovascular issues as well. So we're not simple creatures. We have a lot to think about, but all of these things make us able to have a very valuable contribution to research. So these are just a few of the things that I do. So as lay advisory group lead at Kidney Research UK, as a group, we're advocating for patient involvement in research funded by Kidney Research UK. We provide patient insight for the work of the charity in strategy, policy, external affairs, comms, reports, conferences, committees. We represent patients on external committees like for NICE, for industry, MHRA, and we also have patient representatives on clinical study groups and research networks. I'm also the patient co-chair of the UK Renal Health Data Research Network. I've just organised a series of patient data webinars. Some of those are about kidney patients particularly, but kidney data, but some are more generic. They are on the Kidney Research UK YouTube channel. And I'm also involved in encouraging patient involvement in kidney data research projects. And I've just recently become a public contributor to the British Heart Foundation Data Science Kidney Data Catalyst. And I also like publishing things. So I've published a little bit on amplifying the voices of kidney patients and some more on shared decision making. So that's just a few of the things that I do at the moment. I thought I would stop there because I've gone on for quite a long time, but I'm really happy to take any questions, have a little bit of a discussion. And thank you for listening to me.